The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, all TMD warriors. Good day to you. I am Tony Urbanek, and this is the next episode of TMD Demystified. The topic today for this week is protrusive habits and protrusive traction. That may or may not make any sense to you right now. I've covered this briefly in other episodes, I believe, but we're going to take a little deeper dive today into those two concepts as it applies to what? TMD, jaw joint problems. Very, very important concept, though, when it's well understood and well applied. What triggered this is, and I triggered it actually several weeks ago, seeing a patient. That's usually what triggers most of my topics for podcasts, episodes, is something happens within the consultation or the delivery or with a patient that emphasizes some aspect of treatment that needs to be developed and taught to any prospective doctors who use the device and protocol for their patients. So what happened was I had seen a patient, typical middle-aged woman who had 20, 30 years of pain, headache, earache, jaw pain, etc. Delivered the device, and she came back in 3 weeks. And as we know, the average number of, not the average patient, but the average number that the patient at 3 weeks says what percentage of their symptoms are diminished or gone, whatever those symptoms were on the list. The average is 70%, can be more, can be less. This patient came back and said, I don't know. I don't remember exactly. I don't have much change. I haven't much change. She might have said 10% of her symptoms were changed. Well, that's very unusual. It happens, but it's very unusual. Now, after treating more than 3,000 patients and doing more than 5,000 consultations on this problem, I know what to look for and what to listen for. And so as I'm talking to this woman, middle-aged woman, and I didn't say anything when she said, I haven't noticed much change at that time, but I'm watching her and I'm thinking, well, what's my next move? And I'll tell you in a moment what I'll usually do. It goes one of two ways. But as I'm watching her, she's going with the device in her mouth. She had the device in her mouth. She promised me that she was wearing it faithfully 24/7. Thank you very much. I appreciate that, I said. And I'm watching her, and as she's speaking, and as I'm listening to her tell me that only 10% of her symptoms are diminished or gone, she's doing that. She's protruding her mandible. Excuse me for laughing, but I mean, see, because what my experience, what I know about this is this. One of the best ways to damage your joint is to pull it apart. Now, I don't care whether you're talking about a knee or a hip or an elbow. If you want to damage the joint, just keep recurring pulling it apart, and you're going to damage it. I mean, what dynamics are involved, what are the forces, exactly how that affects the meniscus, that's debatable and can be discussed. But I can tell you with certainty that if you constantly pull the condyle out of the glenoid fossa, you're going to mess things up. It's going to damage it. And when you damage a joint, the physiologic response is what? Chronic inflammation, which is what? Chronic inflammation causes all the symptoms. So, I mean, it didn't take my breath away. Actually, I've seen it. Honestly, I've seen it at least 100 times. I don't want to, because I've seen so many patients, but I've seen this many, many times. I've seen it happen with patients who are having a good response, which is great. But when I see somebody who is not having the expected good response, I'm looking for it. I'm actually, now more than often, I'm looking for it. And quite frankly, sometimes I'll address that. What percentage of patients come back at 3 weeks and says, I don't know much difference? 1 out of 50. And it goes 2 ways. Depending on, first I have to have a good belief that the patient has used it 24/7 for 3 weeks. I believe most of my patients are honest. Obviously, I have had a few patients who are not, and I have had actually more than those. I've had patients who are honest, but tell me, I haven't worn it 24/7, at which point that's a different story that is covered under the topic of patient compliance. All right, so, but the point is that when the patient has a chronic habit of moving the jaw forward, they're pulling the condyle out of the fossa, and over a period of time that will damage the joint. And even with the device in place, you're working against the operation of the device and protocol, which is no more, no less than taking the load off of the temporomandibular joint and allowing the condyle to go back to its respective healthy position. Let me define healthy position. It's like, what is the healthy position? It isn't back as necessarily as far as it could go. It isn't like pushing it into the glenoid fossa. It's the position that allows the mandible and the condyle at the end of the mandible to go back to its most physiologic position under the circumstances. In other words, the best centric relation under the circumstances. For those that are extremely well schooled in centric occlusion, centric relation, I mean, there's all kind of philosophies about this, but in doing an exam, you can push the mandible back to its most posterior superior position, and that's where you take a centric relation bite. Well, that would be your most honest, significant centric relation bite, but it may not be the most physiologic for the joint. So the point is that centric relation, when you unload the joint in the most physiologic position, will give you the best response to decreasing the inflammation. And I saw this in a patient, and when I see that, the solution is to bring it to the patient's attention. And when you bring it to the patient's attention, quite often they don't know they're doing that, and it's a habitual thing. It may have to do with them trying to get around the device and bring their mandible forward, playing with the device, and it's something that they may do naturally. And it brings me back to years and years ago when I first started. I mean, this was a good 10 years ago. I found, I examined and did a consultation for a young 16-year-old female, very pretty girl. And when I examined her, her centric occlusion looked fairly normal. Her facial profile looked fairly normal. But when I did a thorough examination, I found that her centric relation and centric occlusion were that far apart, and that she had found that it looked so much better to bring her mandible forward to a centric occlusion. She did it for looks. She did it constantly. She had a class 2 occlusion. She had a class 2 mandible. She had mandibular retrognathia. which is right up my alley as an oral and maxillofacial surgeon. But she had learned to hold her mandible forward because it looked so much better. She was a typical 16-year-old female who wanted to impress whoever 16-year-old females want to impress. And she was in my office because she was having terrible headaches, terrible headaches and jaw joint problems. This is just one of hundreds and hundreds of examples that I've come across over the years treating this problem non-surgically. Now, I don't want to digress too far. I want to jump on a concept that I kind of went around. So when a patient does come in at 3 weeks and they're not getting the response that I would expect, which would be somewhere between certainly the low point, 30% of their symptoms are diminished or gone up to 100%. They get down into, I haven't noticed any difference, or I've just noticed 10%. It can go 2 ways. And it depends on, I guess, my feelings of that day. Number one, I can say, well, just hang in there, because on many occasions, going that next segment, that next 6 weeks of 24/7, they will come back now at 2 months and they will give you a much better number of the question. Take all your symptoms, average it all out. Don't lump the symptoms together. Don't separate the symptoms out. Lump it all together, average it all out, and tell me what percentage of your overall symptoms are not diminished or decreased. And quite often, when they don't have a good number at 3 weeks, they will come back at 2 months, and with an additional 6 weeks of 24/7, and they will be up in the 70s, 80s, or higher. Or if I really feel that we were really not made any progress at all, then I will adjust the device and increase the vertical dimension, which is covered several other places on the course and several other places in the episodes of the podcast, and why that is and why it's important. How do you do it? And simultaneously, I will be looking for a patient who has a protrusive habit. And quite often I will see it, and the patient's not aware of it. And why they're doing it is variable, but it's a habit. And then I show them that they're doing it, and they go, oh, and I say, so the solution is like, don't do that. And in many cases, many cases, once you bring it to their attention, they'll try to cut it out, they'll cut it down, and then the device itself will take its normal action, which is bringing the mandible and the condyle back into a physiologic centric relation position. And they will begin to get relief of their symptoms associated with chronic inflammation within the temporomandibular joint. Quite simple. And I hope I explained it well so that you follow that along. It's quite simple. Besides protrusive habits, what I have found on many occasions, listening to the patient, again, I just did an episode on just listen to the patient. It is so beneficial to you as the doctor. You learn so much and you can apply it. I'm trying to shortcut it for you. I'm trying to tell you what I've learned, but do it yourself. I mean, listen to the patient's history, their complaints, what has gone on, what they've done for their symptoms, and you will learn a whole bunch of stuff, especially things that aren't effective, but things that actually complicate it. And one of the things that really causes or complicates temporomandibular joint symptoms is protrusive traction, or traction on the mandible. This may open up a lot of comments from my orthodontic colleagues, but I stick by it. I mean, I've seen so many patients who have had extraoral and intraoral devices, orthodontic devices, placed on them to pull traction on the mandible, which, just like a protrusive habit, will distract the condyle out of the fossa, which is not physiologic, which over a period of time will create chronic inflammation, which will, over a period of time, create temporomandibular joint symptoms. It's that simple. So I would caution and ask my colleagues who do orthodontics, whether they be general dentists or orthodontists, consider strongly whether or not it is appropriate to put traction on the mandible, whether it be from a head frame or a Herbst appliance or any other kind of traction on the mandible, because I see and have seen over many years, many patients coming in, and part of their history is, oh yeah, I had my orthodontics done and I started having TMJ problems. I started having these symptoms after orthodontics, especially on younger people. And now I see it's more and more and more common for orthodontics to be placed earlier and earlier and earlier. That if you understand facial growth and the growth of the condyle and the growth of the mandible due to growth within the condyle, you'll come to understand that putting traction on this joint is not a good idea, especially when they're younger. There's some theories out there that, oh, you can enhance growth and you can enhance mandibular growth. Those are theories. And be very cautious about that. Again, as a maxillofacial surgeon, I just seen so many cases of true retrognathic mandible that needed to be handled with orthognathic surgery and a combination of orthodontics, which is the proper way to handle it. Orthodontics alone, when you have a significant retrognathia, is not an appropriate way to handle it. You can not only not get the problem solved, you can't move the mandible far enough forward, but you can create tremendous amounts of damage by a extraoral, intraoral traction on the mandible, pulling the condyle out of the glenoid fossa. And the younger the patient is, the more probability there is that you can damage that patient's joint, create chronic inflammation, and therefore create TMD symptoms. And the third part of this that stimulated this particular patient talking through protrusive habits, which is that, reminds me of one of my children, little girl, Kelly. If you ask her when she was 5 years old and if you ask her to smile, she would do that. We have a bunch of pictures with smiles of her going like that. The third part of this is orthotics. Orthotics can be sleep devices and they can be TMD devices. I still, as an oral maxillofacial surgeon, in my history, did quite a bit of orthognathic surgery, bimaxillary advancement for sleep apnea. I won't go through why that works, how it works. It's a big operation. It's very effective for people who have very severe, untreatable sleep apnea. But there are oral devices that I am still asked to use by some patients, nowhere near the amount of TMJ patients that I see, but people are sent to me for a sleep device for their sleep apnea, which is nothing more than, those of you familiar with this, two pieces that one fits over the maxillary teeth, one fits over the mandibular teeth, with a strap or traction of some kind pulling the mandible forward. Without getting into too much about sleep apnea and why that works, but it works. It works in many patients by increasing posterior airway behind the tongue. But what it also does, it distracts the condyle out of the glenoid fossa. And I have seen those patients who have been in one of those sleep devices for sleep apnea long enough where they've come in and begin to complain of one or more of the symptoms of temporomandibular joint problems, chronic inflammation in the joint. And why is that happening? Because that sleep device is pulling them forward. And the second category are different devices that I've seen used from time to time out of different offices with different theories that believe that an orthotic that directs the mandible forward on a plane, on an anterior plane, will somehow help temporomandibular joint symptoms. Well, again, whether you direct the mandible forward with an intraoral, intraocclusal device, which brings the mandible forward, Or you use a sleep device, which by traction on those straps brings the mandible forward. Or you use orthodontic devices, both extraoral head frame or intraoral Herbst device or similar device, which brings the mandible forward. What they all have in common is they distract the condyle out of the glenoid fossa, which over a period of time will cause damage of one kind or another. And once the damage is caused, then the body's response is to create chronic inflammation. And it's the chronic inflammation that creates all of the symptoms directly, which is I've covered several times, several episodes, and it's on our course as to why chronic inflammation will cause directly, without any intermediaries, frequent or recurring headaches, earaches, jaw pain, neck pain, ringing in the ears, tinnitus, feeling of fullness in the ears, like you've been swimming and can't clear your ears, vertigo, dizziness, shoulder pain, arm, hand, finger tingling, and numbness, and various kinds of locking of the mandible. So protrusive habits, look for them in patients that you see with TMD symptoms. You will frequently see them. And when you see them, bring them to the attention of the patient, encourage them to cut it out. And frequently they will. I mean, you can break a habit during the day. Now, if they have a protrusive habit at night, and that can occur, I tell my patients, you have no control of what happens at night. I'm not asking you to control what happens at night if you are doing it at night. We don't know. We're not going to find out. But if you do it during the day, you are doing the contradictory motion that needs to go on with making your TMD device, the Urbanek device and protocol, effective. It will be effective if you don't go in the opposite direction. So that's what I have to say today. I hope it made sense. I hope it's certainly, in my mind, very simple. It's simple, and I try to treat simple. I try to express and teach simple concepts on this problem. That's why I named months ago this podcast TMD Demystified. There's no mystery to this. So as always, I appreciate you listening. I appreciate your attention. I would appreciate your comments. I would even appreciate if you disagree with me. Not a problem. Be happy to respond to anybody. And if you'd like to talk with me, I can be reached at tmjservices.net. If you'd like to find out how you could become a network provider for TMJ services and use the same device and protocol that I use on hundreds of patients a year. We now are referred in here in Middle Tennessee, on average, 100 new TMD patients a month from mostly medical providers who misdiagnose, mistreat, misdirect these patients, but also my dental colleagues, many general dentists, my orthodontic colleagues, my oral maxillofacial surgery colleagues know that we treat TMD effectively non-surgically. So if you'd like to learn how to do that, take our course, be licensed to use the device and protocol, you can contact me, or you can contact Naomi at tmjservices.net. You can get more information from our website, www.tmjservices.net. With that said, I wish you a successful week, and I look forward to speaking with you next week. I am Tony Urbanek, and this is TMD Demystified.